this session. In today's session, we are joined by Professor Yap Boom, the Deputy Incident Manager of the IMST based in DRC. And we will also be joined by Dr. Ngashi Gongo, the head of the IMST based in DRC as well. I will now hand it over to Professor Yap to start the session. Over to you, Prof.
Thank you, Margaret. Good afternoon, good morning, good evening, dear colleagues. It's, of course, our pleasure to have you all around for this press conference. And I will be talking on behalf of the DG, who is not able to join the call, but also on behalf of the entire MST. So over to you, Margaret. I think we can start taking the question.
Thank you, Prof. Let's just project the presentation.
Margaret, can you still hear us?
Yes, sorry for the delay. We are about to project the presentation.
Okay, then it's good. So sorry again for this challenge with the technology. I will take advantage of this time to acknowledge all the colleagues, to present all the colleagues who are currently in DRC, in Goma, and elsewhere fighting not only the Mpox outbreak, but all the different events that we are facing currently. As you will see during the presentation, Goma and the eastern part of DRC has been quite exposed and challenged by this crisis, which has led to quite a number of challenges in terms of people who are being affected, people who will kill. We will give some number later on. But despite that, our colleagues from different organizations are being in the forefront, trying to wait, and while waiting the support in terms of the community so that they can have that humanitarian corridor that allow the support to come. They have been working tirelessly in these very difficult conditions. So I take advantage on behalf of the DG of Africa CDC to thank them, to acknowledge all the great things that they are doing there. So we'll try to see whether it's working now. Hold on. So thanks for your patience. We are trying to solve the issue. The main challenge, as you may know, our colleagues and all of us based in DSC has a lot of challenge with the internet connection. So we hope that it will be uploaded as soon as possible so that we can start our conversation. Yeah, Margaret, should I try to, okay. Are you sharing? Okay, thank you. So thank you so much, colleague, for your patience and apologies for the technical issue. So again, welcome to this weekly press briefing. So we'll be sharing with you the situation that we are facing currently in the continent as Mpox is concerned. But as you will see, we are quite challenged by other epidemics, including Ebola, but also Marburg, as you will be seeing. Next slide, please. So as far as Mpox is concerned, in this month, the first to the fourth week of 2025, we have 13,000 cases that were notified and confirmed 107 deaths in 12 countries. So currently, we still have those 12 countries that are in active phase, which does not mean that the 9 countries that are in a control phase should not be watched. Instead, we should keep on ensuring that we support the country so that we can see that they keep on the surveillance, as we'll be seeing later on. So in this week of EP4, 8 countries have notified 2,635 cases, 878 were confirmed, and we have 28 deaths. But due to the situation that we've seen currently, and that I will come back later in the eastern part of DRC, the laboratory have been quite affected, especially the ENB lab in Goma, which actually run the sample not only for the North Kivu, but also the region around that. But we have some good news. Uganda has commenced the Mpox vaccination on the 1st of February, and we do believe that this will be a game changer, not only in Uganda, but in all other countries where we are pushing, supporting member states to accelerate the vaccination. Next slide. So when you look at the landscape of the different countries that are currently active, starting by DRC, Burundi, Nigeria, Ivory Coast, and so on, you will see that with the red round, that the DRC, the Uganda, and the Zambia are the country where we still see an increased number of cases. This has been seen recently. And as DRC is concerned, together with Uganda and Burundi, they currently represent 97.5% of all the new cases that we've seen during the week 4. Next slide. Now, we are still challenged. Last week, we were reporting that only Uganda was showing an increase of 28% in the case. Now we have those 5 countries, Zambia, Sierra Leone, that are new cases, 15 cases for Zambia and 16 cases from Sierra Leone. while Uganda and Congo, we are seeing an increase for more than 100%, up to 200% in Congo. In DRC, we still see an increase, while in all the other countries we see in green. We are happy to see the decrease, though we still need to be very careful and ensure that the surveillance is still working. Next slide. So in Uganda, as we do speak, last week we've notified 540 cases as compared to 517 last week. And as you see, the case fatality rate is 0.6. This is among the confirmed case. And as I was mentioning earlier, the good news from Uganda is that they are currently started the vaccination. And we do believe that the vaccination is really a game changer because it will give the opportunity to some exposed population to have access to a protection which might not be possible otherwise. Next slide. Now, when we look at the age-sex distribution in Uganda, one, you can see that the actually epicenter, the hotspot, are around Kampala, Wakiso, and you can also see in the age group the distribution. You have a population between 18 and 39 that are the highest represented population, which make us think that what is happening is really happening within the sexual network, which make very complex the response, because in that population it's very hard to be able to do the contact tracing because of the confidentiality. And if you don't do contact tracing, it's very difficult to know where the new cases are moving, also because of the high mobility of the population, which is considered with sex driver, with truck driver, sorry. Next slide. In Uganda, in Burundi, sorry, we are now seeing a decrease in the number of suspected cases, but also in the number of confirmed cases, which is a good news. Knowing that the testing coverage is quite high, 99%, with a positivity rate of 51%. But we still need to be very careful, as we all are when we see a decrease, because we still see a long turnaround time between the investigation and the lab confirmation, which means that there are still some possibility of high transmission within the community. So yes, we are happy to see the decrease, but also, as discussed this morning with our colleague from Burundi, we need to intensify the surveillance and especially the community engagement, where community health workers are also part of that response. Next slide. In Zambia, when I was starting the presentation, I was highlighting those countries where we have seen cases like 6 to 7 weeks ago, then nothing. And now, since the week one, we are seeing an increase in number of cases, which most likely mean that there has been some case circulating without the community, without the country being able to detect. So that highlight two things. One, it's critical to carry on the surveillance. Two, it's important and critical to ensure that the diagnostic also work hand in hand with the surveillance and the community engagement so that the case can be captured at the early stage within the community. So that's a country that's a very good testing coverage as the previous one with 100%, but need to be monitored and support. Next slide. Now, DRC. DRC, as you can see in the graph, there is a decrease in the number of suspected cases and confirmed cases. But knowing that the North Kivu is the epicenter with the highest number of cases, and now that is affected by this current situation, the decrease that we are seeing may also be explained partly because we no longer have data and testing being done in that region. Next slide, please. So coming to that, we have the challenge of multiple outbreak. We have the Mpox. We also have now, because of the situation, measles that might be increased, cholera might also increase. And you see how it's affecting the capacity of laboratory to detect the case. If you see on here, on the eastern, you see the North Kivu, it used to be on orange. But now, if you see in the week 4, the same province, it's now in pink, while the region next to it, which is the Tropo, is quite gray. What does it mean? It means that the region like Tropo, that is relying on Goma, which is a North Kivu, for the testing, is now also affected. And if you don't have testing, you know the implication in terms of case management, in terms of contact tracing, and also in terms of spread of the disease within the other different regions. So the steep decline that we see now in North Kivu and Tropo is also another direct impact of the armed conflict that we are seeing. On top of that, the insecurity also impact the shortage of lab consumable, but also all the other intrant that medical countermeasures that are needed for that response. Next slide. So far as last week, from the source of the OCHA, the death toll were around 900 patients that was dead, 208 injured as compared to last week. Other challenge, during that time, we have reported 128 active Mpox patients that has no choice but to run away from the health center where they were treated because of surviving. 16 of them has been recovered and went back to the treatment center, but all the other are still spread, not only in Goma, but also in the neighboring region and maybe also in the neighboring countries. The other challenge that we are seeing is the delay and improper handling of disease, as we see, and as we've been heard by the colleague who are still in the ground, and also the challenge in the IDP camp that are now overwhelmed, some of them. The air operation in North Kivu is suspended, and the road operation are compromised due to the M23 forces. The WFP warehouse, but also other partners, MSF and others, have seen looted and lost significant amount of food. This is for WFP, but also the warehouse and the other medical operation has been suspended for some of the partners. So currently that discussion ongoing with the government, with the partners on how to implement a humanitarian corridor so that the countermeasure can be sent to the North Kivu, but also the human resource. Currently in the North Kivu, only 18 surgeons were there for all the amount of population. So the idea was to ensure that human resource, doctors, IPC specialists, lab people will have the opportunity to go and support the situation there. Next slide. So for the Marburg in Tanzania, since last week, there has been an increase of 1 case compared to that week, and the locations are still the same in Biha, Maulo district, Kagera region, at the borders with Burundi, Rwanda, and Uganda. And this highlights the challenge of the cross-borders surveillance, because you can see how the location of this country as compared to the other Burundi in the nearby Rwanda, where we used to have an outbreak, highlight the challenge of emphasizing the surveillance within country, but also at the borders where the patient may be moving from one side to the other. So currently there are 281 contacts on the follow-up, 132 complete the 21-day follow-up. The case management is ongoing, and the risk communication and community engagement, which is quite critical, and on ensuring that the community is aware, prepared, and in a position to respond to that outbreak is also ongoing. Next slide. So when we look now at the epidemiological curve of the MVD outbreak in Kagera, you can see the number of confirmed deaths, the 2 deaths that has happened just last week. When you move now in trying to understand who are those people, you will see that the majority of them were more than 15 years, with 2-3 of them between 30 to 45, and then 3 also more than 60 years old. Next slide. Now, on top of the Mpox situation that Uganda is seeing, And then we've seen that the number of cases of Mpox have raised for almost 100%. There has been the declaration of the new Ebola virus disease, Sudan in Uganda. And the location that has been highlighted as epicenter was Wakiso, Jinda, and Mbale, with 207 contacts under follow-up. But the good news, because we need some good news, is that the vaccination trial has started. The first one targeting the Sudan Ebola virus disease. The therapeutic trial are in process, in discussion, together with the WHO, the country, and Africa CDC, of course. And we have already all together deployed some experts to the field so that they can work under the strong leadership of the Ministry of Health to provide added value in the response, especially in the surveillance, but also at the point of entry and exit screening as is being implemented. Next slide. So, in summary, we can see how the crisis, the humanitarian crisis, is also affecting the response to Mpox. In Goma, the interruption of the INAB lab is currently reinforcing the need for decentralization of the lab, because you've seen that some regions are now affected. The IPC is critical because we need to handle all those coughs that are being seen in the hospital, but also we need, in terms of surveillance, to strengthen the population mobility so to know exactly where are those people moving so that we can position our team to respond and address the movement of the IDPs. With the corridor that we hope will be open soon, we'll be able to support with essential health services to displaced population, which will include the lab, but also the case management and the IPC to avoid other epidemics. We talk about cholera, measles, and so on, to avoid them to be able to spread within the country, within the region, but also in the neighboring country. So in Uganda, as we mentioned, we should support the country for Ebola Sudan, but not at the expense of Mpox, of course, which lead to an integrated approach in responding to those outbreaks. And that needs a proper and strong coordination in which Africa CDC will be definitely supporting the country. And to achieve that, we definitely need to have more domestic resources so that we have the autonomy to respond wherever we are needed and support member states. Thank you. Margaret, over to you.
Thank you very much, Prof. We apologize for the earlier glitch in the presentation. We'll now take the first two questions from the chat. The first question comes from Christopher from Science Now magazine. He asks, how are you supporting Uganda to manage the increasing cases of EVD? That's the first question. Let's take the second one. Second one is also on Uganda. This comes from Nadine from the Conversation Africa. She asks, tell us more about the vaccine trials in Uganda. How many people have been enrolled and what is the criteria? Over to you, Prof.
Thank you so much, Christopher and Nadine, for the question about Uganda. So currently we have a team that is present in Uganda to talk with the Ministry of Health and to see where we can actually provide the best support. So we had some IPC specialists, infection prevention and control specialists, that were deployed here for the Mpox, and they have been reassigned by the Ministry of Health to provide stronger support on Ebola. So we are trying to ensure that we have that integrated approach and support the country. And we have a delegation that is coming today to support the coordination. So in terms of vaccine, the trial has started, and more information on the numbers will be provided most likely Saturday when they will do the briefing of all the week of this new breakthrough.
Thank you. Let's take the next two questions from the floor. Paul from the Lancet, you have the floor. Over to you. Paul, can you hear us?
Yes, I can hear you. Thank you very much. I would also like to start from the Ebola virus.
I have difficulty to hear Paul.
Clinical trial. Can you
Sorry,
hear me?
Paul, we are losing you. Maybe if you could restart your question. Thank you.
Can you hear me now?
Yes, we can
Yes.
hear you.
So my question has to do with the clinical trial too. Do we have an idea of what the respective roles of the different partners would be? For instance, what is the involvement of Africa CDC at this particular moment in for the clinical trial? And regarding disease surveillance, what insights can you give us regarding tracking the spread of this disease and tracking everybody that is a contact of these persons affected? So what progress can you give us on this?
Thank you, Paul. Let's take the next one. Do you have another question, Paul?
No, that'll be all for now.
Oh, thank you. Let's take the next one from Janice from Bloomberg. Over to you. You have the floor.
Thanks again. I missed a little bit at one point, so sorry if I'm asking a question you've already answered. But last week, the DG was saying that he was also concerned that there may be a case of Ebola in the west of the DRC. I was just wondering, he said that had been sent off for testing, and I was just wondering what came of that. And then my other question is not directly related to any of the diseases we've talked about today, but in light of all of these diseases and outbreaks, is there increased concern from the Africa CDC for bigger risk around antimicrobial resistance? You know, when you've got so many things going around, I do worry about the actions that have to be taken under emergency conditions, and ultimately, you know, reversing a trend globally of trying to use fewer antibiotics and fewer, just increasing the risk of resistance in that way.
Thank you very much. We have Dr. Ngashi with us now. Dr. Ngashi, welcome.
Yes, thank you very much, Director. I think I can take Janice's question about the concern about the case of Ebola in the Western DRC. That was in the Equateur province specifically. I think the first testing was done in Mbandaka. It tested negative. And then because we were so concerned, given the fact that the case met the definition of Ebola, and then the specimens were transferred to the ENRB in Kinshasa that repeated the testing and also confirmed that it is negative. But then what has been taking place is that in collaboration with the government, I think the COSPIA, the NPHI, is sending a team to the Equator region just to investigate and take more samples to understand if it's not Ebola, if it's not Marburg, then what is it? I think that's why the country is in collaboration with Africa CDC. Now, on the question of antimicrobial resistance, I think that is of great concern, given the fact that, first of all, in Africa, the issue of antimicrobial resistance is a combination of the lack of access. That means that health workers tend to use whatever is accessible to them, even if it's not the indication. And also the prescribing habit that is also linked to the skills, of the health professionals. Now when you have context of emergencies, like what is happening right now in the Eastern DRC, that then makes it very, very difficult for you to ensure the quality of care and the proper continuation, of the prescription as given by health professionals. I think that's why the DG made that call last time, that it is extremely important that, on the political side, there is some progress that is made to stabilize the situation, to allow us then to come in with interventions that will help not only Mpox, but the continuation of services overall, and also all the effort to reduce antimicrobial resistance on the continent. Over to you, Director.
Thank you very much. Professor Yap, do you have any additional?
Yes, there was a question on the clinical trial and also the surveillance. on trying to understand what are the role of each organization, Africa CDC, WHO, and so on. So what is quite clear in this outbreak is the strong leadership that the Ministry of Health of Uganda is putting in place. And what they surely don't want is to have different logos. They want everything done within the same coordination. So it would be hard for you to tell that WHO is doing this, Africa CDC is doing that. It's really each partner will, within the coordinations, be able to implement different activities. So we are all part of the clinical trial, especially the upcoming one on the therapeutic as well, all together with WHO and other colleagues. The same thing for the surveillance, the same thing for the community of risk and engagement and the IPC. So see, this is really a coordination, which is the same model that we've been putting in place under the IMST, where we have one team, one plan, one budget, and one monitoring and evaluation framework, so that we really work as together to fight those emergencies. That's a new model of how we want to address the emergency in Africa. Over.
Thank you. Let's take the next question from Gabriel Emmanuel from NPR. You have the floor.
Hi, thank you so much for doing this. I'm curious about collaboration with the US, particularly when it comes to the Ebola outbreak in Uganda and the Mpox, specifically around Goma. I'm curious kind of how the US stepping back from foreign aid has impacted the efforts there as you see them. And also, I know Biden's team administration had pledged $500 million and 1 million vaccine doses. So I just wanted to get an update on where that money and where those vaccines stand. Thank you very much.
Thank you. Let's take the next one before the responses. Anate from Reuters, you have the floor.
Hi, can you hear me?
Yes, we can hear you. Go ahead.
Yes, thank you. So I have a different kind of question about the US. We reported that the US is considering reforms at WHO, including pushing for an American to be in charge. So what do you think of this, and what should the WHO do to stop other nations leaving? Have any African countries told you that they might leave WHO?
The response from Dr. Ngashi. Dr. Ngashi, over to you.
Yes, thank you very much for really those very interesting questions. First, starting with Gabriel on the collaboration with the US. There's no doubt that the US has been one of the main partner of public health on the African continent, both for endemic diseases like malaria, HIV, and also for emergency responses. We've always collaborated with US agencies, both the US CDC, USAID, and different agencies, really, to push both the preparedness and the response during outbreaks. And we know that even in this response, USAID was among the very first organizations to really invest in the Mpox response, pushing both the surveillance, the laboratory testing, and also the involvement of community health workers. But so far, we haven't seen any negative impact of the decisions, because most of these commitments so far, if we take the funding out of the 500 million that the US had pledged, more than 314 million have already been committed. That means that this money has already been dispersed to the implementing partners on the ground. On the vaccine side, we still hear that those vaccines will be going through Gavi, and that there's not yet, as far as we know, any change in that commitment. But it is something that we are following up very closely. And also for us, it is also a wake-up call for African member states to also step up and start also pushing a lot of investment in domestic resources. I think that's the lesson that we are drawing out of this. But at this stage, we haven't yet documented the application of that on the African continent, and therefore also any negative impact that is related to it. Now, on the question about WHO, that is a very difficult question in the sense that WHO has got its own nomination process, which is more of a global process that includes really negotiation with many constituencies that contribute to the choice of the leadership of WHO. Africa has already been represented by Tedros, and we'll expect that with the usual rotation, I think the next leader should come from another continent. Now, we haven't heard anything from any African member state so far. As you know, that the support of African nations to the current leadership of the of WHO at global level has been unwavering. And also, I think they continue to support until further notice. Now, what is happening between the US and WHO is something that the African member states so far haven't taken a collective position. But what is sure is that they would like really to see the normalization of those relations, given the important role that the US has always played in global public health. Over to you, Director.
Thank you, Dr. Ngashi. Let's take the next question from Helen from STAT. You have the floor.
Thank you very much for doing this and for taking my question. Earlier this week, scientists from Uganda very quickly published a report on the genetic sequence of the Ebola Sudan virus that's responsible for their outbreak. And with their analysis, they could determine that this was not a continuation of the outbreak from 2022, but that the virus was more closely linked to an outbreak that had actually occurred in 2012. I'm wondering, I'm pretty sure that Tanzania has sequenced their virus. And of course, there would be questions about whether or not their Marburg outbreak is a case of viral persistence from their 2023 outbreak, or if it's possible that a case from Rwanda had come across the border and undetected and had triggered the outbreak in Tanzania. So I'm wondering if you folks have any idea whether they are the results of their sequencing effort public. Thank you.
Thank you. Let's take the next question. Carmen from Politico, you have the floor.
Thank you, Margaret. I also wanted to ask something related to the U.S. Last week, the DG, welcomed the fact that the State Department here had given a waiver to PEPFAR funds from the foreign aid freeze. I was wondering if you've seen on the ground a restart of these activities, if sort of like, a provision of antiretrovirals testing, all of that has returned to normal after that waiver, or if you're still seeing disruptions. Thank you.
Thank you. Over to you, Dr. Ngashi.
Yes, thank you very much, Director. I think on the first question about the genetic sequencing in Uganda and Tanzania, I think Prof. Yap is in Uganda right now. I think from the meeting that we've had yesterday and today, Prof. Yap, is there any information to the sequencing of the current outbreak of Ebola and the possible link to the 2012?
Sorry for the big noise. Not yet, but we will be having a meeting tomorrow where all those questions will be communicated. So we'll be able to give more insight next week during our press conference.
Yeah, I think we'll know more, Ellen. What we also need to factor in here is the fact that these are zoonotic diseases. And that as much as we've been pushing the One Health approach, but the reality is that on the animal side, I think efforts are very weak. That means that the control of the circulation and the transmission on that side has been very weak. And also, this is also happening in the context of weak surveillance system. I think that's the reason why we are more interested to see if some of these, whether it is the Marburg in Tanzania or the Ebola in Uganda, there is some element of ongoing transmission that has continued, undetected until we see new cases surfacing. But as Prof. Yap says, for Uganda in particular, I think the meetings will give us more light into that. Now, on the question about the disruption in, on the delivery of HIV intervention, both testing and antiretrovirus, I think we haven't observed that, at least seeing that on the ground, in the member state. But as you know, this is something that we are also monitoring very closely to make sure that people abide by the decisions that are made, in the US, so that they don't jeopardize. I think the many people, I think thousands and thousands of people that are benefiting from these services. But so far, no damage yet observed on the ground. Over to you, Director.
Thank you very much. Let's take the next two questions. Priyanka from Chemical and Engineering News, you have the floor.
Hi, thanks for taking my question. I know there was discussion about Tanzania considering the use of a candidate vaccine and antivirals, similar to what Rwanda did when they had the Marburg virus outbreak. Could you just let us know what's happening on that front?
Thank you. Let's take the next one before the response. We have Esther Nakazi. You have the floor.
Thank you very much. My question about, can you hear me?
We can hear you, but there's a bit of noise on the background.
Okay. My question is about spillover, especially in the diagnostics, especially right now where we have Marburg, Ebola, Mpox, and the lab people are handling this. What's the likelihood that the diagnostics are not working very well and we do not have a lot of accuracy? I'm just thinking that that is happening. And secondly, Professor said there is a new model that I want him to explain more about between WHO and Africa CDC working together. How is that happening? And what is each of them handling? You said you're doing it together, but I explicitly want to know how that is happening. Thank you.
Thank you. Let's take the first response from Prof, and then we move on to Dr. Ngashi. Prof, over to you.
Yes, thank you. Thank you, Priyanka, for the question on the vaccine and therapeutic in Tanzania. So we currently have a team that was engaging the Ministry of Health to see what is the best way to put in place those trials. Those trials need some good time to prepare, and we hope that in the coming weeks, in coming days of week, we'll have a better understanding on how those trials will be able to be implemented. So far we are monitoring, and our team is there on the ground.
Thank you, Dr. Ngashi.
Yes, I think just to follow up on Priyanka's question, it's one of the challenges we have right now when it comes to therapeutics for the trials on remdesivir. The problem is that all the cases now have died. As you know, there were 10 cases, all of them have passed on. I think there's no case for now that the therapeutics can be tried. But as Prof. Yap said, we have the team right now. I think we are also working together with WHO to coordinate the research agenda around these medical countermeasures in Tanzania and Uganda as well. Now, the question about if I can start with the new model of collaboration and the division of labor between the two. I think this is the very first time that in the history of the two organizations that we decided not to have incident management support teams in each of the organization, But now we are trying a new model where we bring the two organizations to sit in one place, have one single team that is co-led by both, but bringing all the other partners together to sit with Africa CDC and WHO in a coordinated manner. We have about 28 organizations, I think, that are working with us. In the Continental Mpox Incident Management Support Team is being co-led by WHO and Africa CDC. I'm the co-lead on the part of Africa CDC. We have Dr. Guy, who is also the co-lead on the part of WHO. Now, the responsibilities is first of all, the two of us is to oversee the entire operations, of the Mpox response on the continent, both preparedness and the response. But within that, we identified 10 different pillars. And those pillars where we have the comparative advantage of each of the organizations leading, where we can lead. For example, when it comes to treatment, you know that's a comparative advantage of WHO to lead on the treatment pillar. And when it comes to, for example, laboratory, we see Africa CDC playing a much more prominent role. That's what we do. But we also have created space also to take into consideration the comparative advantage of other partners also that have a role to play. For example, when it comes to the nutritional support, we have UNICEF and the World Food Program, I think, that are leading there. When the psychosocial support, we have UNICEF taking precedent on that. When it comes to surveillance, we see a much bigger role of European CDC and the US CDC also coming, to provide their expertise. I think that's how, with a clear division of labor within those 10 pillars. But on top of that, we have WHO and Africa CDC doing the representation, and the oversight of the entire support team responding to the Mpox response, and now also to be extended to Ebola and Marburg. Now, there was another question about the risk of spillover and the challenges of the diagnostics. I think that might be weak. I think it is a real challenge, especially that this is happening in countries like where you have Uganda on one side, and then you have the DRC on the other side. And both environment, for example, are environment that are prone to Ebola. You know that there was also in the Eastern DRC Ebola a couple of years ago. But the good news is that we have really worked to strengthen the diagnostic capacity in all these countries, all of them with no exception. They have the capacity to do the diagnostic, they have the capacity to do the sequencing. When we started, there were only 2 countries on the African continent that had capacity to do the sequencing of these pathogens. Today, we have more than 40 member states that have been really given the equipment and also trained to do this sequencing. They are to reassure that on the diagnostic part, I think Africa has got today much stronger capacity than we were in 2022. That's the reason now you heard that even the COVID Omicron, that was diagnosed in Botswana, it was diagnosed with the equipment and capacity that was built by Africa CDC. The same thing, in all these countries. Now, where we are now, taking advantage of Mpox that started, we are now decentralizing the diagnostic capacity to the provinces and to the district. We have a plant here with the DRC, with Burundi, with Uganda, where we are decentralizing that capacity to make sure that at least the minimum diagnostic of these pathogens can be done at the lower level, at the district level, and then the sequencing can then be supported also from the national level. Even in some places like DRC right now, we have sequencing already in 2 places, and the plans are there to support also rolling that out. They're to reassure that on the diagnostic side, I think we have good capacity. For example, the case that where I received the question before in the Western DRC, when the diagnosis was done, the testing was done both for Ebola and Marburg at the same time. So that it tests negative to Ebola, then it is also tested for Marburg. I think on that side, we can say that Africa is in a much better place today than we were 3 to 4 years ago. Over to you, Director.
Thank you very much. Let's take the last 2 questions. Sheriff from the Association of Health Journalists from the Gambia asks, As the Mpox cases surge in Africa, what are the paradigm shift response of Africa CDC in tackling the Mpox outbreak? The second question comes from Lucia Blanco from Spain International News Agency. She asks, thank you for the briefing. Can you give us a total number of deaths and cases for the whole continent until now for Mpox? Over to you, Dr. Ngashi.
Yes, yeah, thank you very much. I think there was a slide that Prof. Yap presented that summarized the number of the total number of cases. I think we are around 85,000. We are around 85,000 cases that are reported. And also the number of deaths, we are around 1,500, around that figure. That's on the numbers. But the paradigm shift, as I was saying, first of all, is just the emergency management approach that has changed completely. This time, we've worked around the 4-1 principles. We have one team, we have one single plan. That was the Continental African Plan that included 29 member states, activities and budget included there, and also the technical assistance budget of partners also included in one place. That's the reason why we went in this more organized way, that we came up with a budget of 599 million, and we got pledges up to 1.1 billion. That to show that it is an approach really that has paid. But beyond that, it's also the fact that another paradigm shift is that this time, learning from Ebola in West Africa, Ebola in DRC, learning from COVID, in 2020 up to 22, there's something that we have wanted is to start with the resilience, building the resilience of the health system right from the beginning of the outbreak response, so that it's not an afterthought, but it is something that we plan right ahead of time, so we can use the resources that are being mobilized for emergency to leave a much stronger system, at the end of the outbreak, and then prepare the continent for the next public health emergency. For example, in this one, we have chosen the decentralization of laboratory as one of the legacies, of the Mpox response. We have also chosen the digitalization of the surveillance system, and also the unification of the surveillance system to have one single database that will be linking now for emergency responses in Africa, surveillance, laboratory, case management, and vaccination into one single database. I think those are some of the paradigm shifts that we see, and also the repositioning of community health workers at the center of health security. You remember that community health workers have always played a role in emergencies, but most of the push has been more toward the support of program to achieve the universal health coverage. Now, this time it is clear that it is a key resource in the health system of member states to help both with the universal health coverage and also with health security in the prevention, preparedness, and management of public health emergencies. I think that capacity is being built. That will be followed up with the mapping of all the community health workers where they are, to be able to account them as a key resource in pandemic preparedness and response. I think those are some of the things that we have seen as a paradigm shift, looking at both the way we manage, what we do, and also the legacy that will be left behind. Perhaps, Director, let me just finish with one thing, that you see, for example, that when we started, it was very difficult for us to get the vaccines for Mpox response. Now we have gotten the vaccines, but now we are going an extra mile beyond that, is now to start now thinking about the tech transfer so that Mpox vaccines in the future can be produced on the African continent, for us to control our own needs, for us to control our own productions. I think these are the paradigm shifts that will really change completely the way that emergencies will be managed in the future on the African continent. Thank you very much, Director.
Thank you, Dr. Ngashi. And with that, we have come to the end of our weekly briefing this week. We'll now hand it over to Dr. Ngashi, for your closing remarks. Over to you.
Yes, thank you very much, colleagues, and all of you for your commitment really to join us again today to get this update from us. I think we feel that we are accountable to you because you are our partners. I think the media, you and all the partners that are connected, you play a key role in really taking the message of the challenges that we are facing, the needs that are still left there, and the support that we expect from the international community really to help us advance into this outbreak. As you have seen that there is really this commitment from the team here, the teams that are responding on the ground, the member state, to make sure that this first quarter of the year 2025 becomes one that will help us bend the curve. We have moved into the acceleration mode. We are really pushing very hard on surveillance, pushing very hard on laboratory decentralization, pushing very hard on community health workers, pushing very hard on digitalization, and pushing also very hard on mobilizing vaccines and improving the coverage of vaccination in the member state. I think we still have a long way to go, but some of the results that we are getting are giving us also some hope. You all have seen the results, I think, that are coming out of Burundi, that when you compare the last 6 weeks and the six weeks before that, we've seen a significant reduction of the number of cases, about 40%. That's what we are really aiming to see in all these countries. But as you can imagine, all that won't be possible if we also create, work together an environment of peace and stability. I think that's the reason why we keep on pushing really as the partners supporting these member states, that all of us also work together to promote the advent of peace in the Eastern DRC and in Rwanda. As you saw that map, the trajectory, of the patients that were in treatment centers that have all really left the treatment centers empty, completely empty. And in the context of what is happening with the risk of other outbreaks already, of cholera might happen there, measles might happen there. I think those are the things that we look forward to really working together with the support of all the key stakeholders to make sure that we can get this Mpox situation under our control. Our key message that with Mpox, it opens up also a door to address some of the systemic issues that go beyond Mpox, but are necessary for us to get this situation under control. With that, we really sincerely thank you again for being there, and we look forward to giving you the next brief next week on the same day at the same time. Thank you.
Recording stop.